We typically have one speaker, but tonight you have the privilege of having three prominent names in healthcare in Southern California and across the United States. And so I know it's going to be a really exceptional time. And what's even more significant about this and impressive about this is all three of them are MBA graduates of the Graziadio School. So we're thrilled to have them with us. And I have to give Richard credit because we had talked to him about hosting and being our speaker, and he said, well, I should get Dave and Artie to come and join us. And I said, well, that would be really nice if you would do that. And so he did, and they were very gracious to acquiesce and be here. So we look forward to it. Really brief introduction of each of our speakers. Richard Cordova is the president and a member of the Board of Trustees of Children's Hospital, and of course our host tonight. Prior to that, he was with the Kaiser Foundation Health Plan and Hospitals. He's actually been in the healthcare field for 40 years, so he's seen it dramatically change for over many years, and obviously has a depth of knowledge and expertise in that area. He's been particularly focused on enhancing diversity in the healthcare industry, so he'll have some interesting things to share about that. He's been recognized, as all of our speakers have, on multiple occasions for what they have contributed to the healthcare industry, so it's a very notable panel. Children's Hospital was actually founded in 1901. They serve over 100,000 children a year here, so it's exceptional to have Richard with us and to be hosting us. Our second panelist is Dave Feinberg, who is, he's got like more titles. I don't know how big your business card must be to hold all of your titles, Dave, but he is the president of UCLA Health System, CEO of the UCLA Hospital System, and Associate Vice Chancellor of the UCLA Health Sciences Center, and so oversees really all of the healthcare aspects of what they do at UCLA. Very, very significant in that regard. He is a practicing physician. His background is in child and adolescent psychiatry, adult psychiatry, and addiction psychiatry, and he still holds a professorship and a faculty position in that area. The UCLA system was actually founded in 1955, and you're from this area. There's multiple elements of that. That's a very comprehensive system here in Los Angeles and serves the community very, very effectively. So Dave, we're thrilled to have you with us and to have your insights tonight. And then our third panelist is Artie Southam. Artie is the Executive Vice President of Health Plan Operations at Kaiser. He has a background in neurosciences and has also got a medical degree as well. Prior to the work he's doing now, he actually was CEO of a software company, Health Systems Design, so he also has kind of a CEO background and a technology background. He has really spent a lot of time, and Kaiser has, on prevention and quality assurance and how we can make sure we're doing a good job of providing quality health care and preventing health issues from arising. Kaiser was actually founded in 1945, and it is really the leading nonprofit integrated health plan in the country. So a diverse and very talented set of panelists that we have with us. So I am going to join them on the stage, and we will begin our discussion. It's going to be a panel discussion, interactive and open, and as we go along, we'll engage you all in that as well. I know we have a very sophisticated healthcare audience with us tonight, so I know you'll have some really good questions for them, and we look forward to the discussion.
Well done.
I'm just going to jump right into the questions, and I'm going to start with kind of a big picture question, and then we can work from there as we go. So this is a big question, but give me kind of your kind of nutshell response to that. How would you assess the current state of healthcare in general? As you think about kind of the big picture of what's going on, both in the state of California and nationally, what would be some, 2 or 3 key points about the state of healthcare? And then we can drill into some of the specific elements of that. Who wants to start?
Well, you're the host.
Okay, I'll start. Thanks, Artie.
I think that sounds like a good reason to make him go first.
I guess let's first start off is that each of us has a different lens how we look at that question, I would think. Okay, and since so I'm going to be looking at it, even though you would have to point out I had 40 years, that I'm going to look at it through the eyes of children. Okay, and I think we're not really delivering on a promise for children in California. When you look at the populations that we serve and the diverse populations that we serve, we see is that me or someone else?
That was one of the children.
Back again. But if you really look at the profile of our children, like in LA County, for example, we've done some work. There's about 2.3 million children 18 and under in Los Angeles County. Over 55% of them are on the Medi-Cal program. Now, I say that because the Medi-Cal program is one of the weakest programs, in my view, in the nation, in terms of the way it's structured, the way it's run. It lacks a lot of real benefit to these children. So we have a lot more work to do, I think, in protecting children, both those that are governmentally sponsored, a lot of uninsured still in our communities. So I'm looking through these lenses, and I think that there's a lot more we can do. Now I'm hoping that some of the transformations that we're going through is going to solve part of that. Trying to get these kids in the right place at the right time to get their appropriate care is very important. But we've got to figure out how we're going to deal with obesity, diabetes, sickle cell programs for these kids, and really kind of work for that. So right now I give California maybe a C+. I think it's headed in the right direction. I know the federal government is investing a lot in California to make it successful in implementing Obamacare. So I'm looking positively. This is, in my view, a glass half full, that we have a lot more to do, but I think we're headed in the right direction in California. But we still have a lot of history to overcome, since I think we've suffered a lot over these years with the finances and the policies of California. So that's kind of a real quick picture in my view.
Very good. Dave, what's your perspective on kind of the state of healthcare?
Well, I would say it's fantastic, but I would add that what I'm saying is really agreeing with my colleague here. It's fantastic because I think we're at a transition, going from a system where we really became the leaders in the technology and the high-tech care, which saved a lot of lives, but got out of control. And we're at this inflection point right now. We're in the middle of it, and I think it's historic, where we're going from a system where most of us, there are some exceptions, and I think they're very notable, we're really paid on volume for healthcare. And we were incentivized as providers to take care of sick people. And we're switching. We're switching to a system where we're going to be responsible for large populations and be aligned in keeping people healthy. The part that I think is really important in all these discussions, if I may add, is that people have to engage in being healthy. So trained as a addiction specialist, you know, the United States makes up, I think, 5% of the world's population, and we consume 50% of the illegal drugs. Well, those are very expensive habits. So, you know, we're overweight, we shoot each other, we drive too fast, and those things, then people say, well, and your health outcomes aren't good. There's a responsibility around health before we even get to health care. Right. But I see the healthcare environment, I'm optimistic, that we're in this inflection that pretty soon, and I think this is the best thing that could happen, we're going to all look like Kaiser. And Kaiser is incentivized to keep people healthy. And Kaiser has done things to engage in communities in ways that makes people live longer. And in addition, which I don't want to lose, is what the academic medical centers bring, is impact and change. So we can blame the United States for high-cost health care and saying, look, it got out of control. But just UCLA alone came up with the first case of AIDS, invented the PET scan, came up with the nicotine patch, came up with the coil that treats aneurysms when you have a brain problem, came up with the first molecular diagnostic treatment for Herceptin for breast cancer. So when you take what academics has done in pushing the envelope and what all of us are trying to do now in embracing populations, I think it's really exciting, and the future to me is one of really sustained health for communities.
Excellent. So Artie, since everyone's going to look like you eventually, what's your take on...
That's why we invited him.
Of course.
Well, I think David's story made me flash back because UCLA is an extraordinary institution, and actually that's where I did my medical school training. And so I recalled that some number of years ago I went to my first clinical rotation, and actually was with Michael Gottlieb, and for my first 6 weeks in internal medicine, I cared for that first patient, or helped the team care for that patient as a third-year student. And actually it's perhaps one of the tributes to the American medical industry and healthcare system, and almost the American healthcare system at its best, at its technological best. The evolution in the prognosis and the care and treatment of AIDS is truly one of the most extraordinary things of our lifetime. So I think you used the word fantastic. Well, I wasn't ready to go to fantastic, but I went to fascinating.
Okay.
And I think that because it is both rapidly changing, it's large, it's big, and I think the other word that came to mind is fragmented. I think that the healthcare industry in particular is fragmented in many ways. It's both institutionally and by verticals. You know, you can meet people in the pharma industry who really know almost nothing about the hospital industry, meet people in the device industry who perhaps have never been involved in outpatient care, and then the insurance industry is an important player and sits separately. And it's actually quite interesting. You can sit with people who run very large public health departments, and they actually have never met a large corporate purchaser of healthcare who might spend $250 million a year in healthcare premiums. So one of the fascinating parts about it is how fragmented, both how large and how fragmented the industry is. I think that makes it complicated. It also, from a consumer perspective and even from an academic perspective, makes it confusing. You know, I think it's complicated and sort of intriguing from an academic and a professional perspective, because I think we all know that there is no end to the learning that can go on about the different parts of it and how they interact. But I think one of the implications of the fragmentation of it, you know, the doctors tend to be separate from hospitals, from pharma, from so forth, and from the insurers, is that from a consumer perspective, it's often, well, who's in charge here, and is there anybody trying to coordinate all this that's going on? And it would really be much more helpful to consumers if it were less complicated, more understandable, easier to navigate, and if people could get their care in a setting where that setting was responsible for the continuous, coordinated, and quality care of that person. I think that, you know, finally the comment is it's amazing biotechnologically in terms of the advances and the nifty and neat stuff going on, but it's really an underperforming industry because the mix of inputs it uses is way skewed to the high technology and way skewed to the treatment of illness and disease, and the underinvestment both of the healthcare industry and public health in the health of the population, and particularly in the social, environmental, and behavioral factors, which frankly are huge determinants of our healthcare. So it's a big industry that of all the 17% of GNP resources, you know, probably if we face up to it, it's misallocating those resources to the extent the objective of it is the health of the population.
Salvador, you made reference to things that led me to ask this, and we're dealing with some of these same things in education and a lot of discussions about the business models and the financial models in education. As you think about kind of the state of healthcare and some of the things that are going on, how do you see the business model and the financial models underlying it changing over the next 5 to 10 years, different from what they've been in the past? And Dave, I'm going to direct that to you because you kind of made reference to that in your comments initially. So.
Well, I think the business is fundamentally changing from one that's based on volume and increased payments for more technical care to one that's based on keeping people healthy and being prepaid for care and aligning the patients and the providers with the same goal. So, you know, at UCLA, for example, we have tonight 800 patients that are going to spend the night in our hospitals. And we're making a lot of money at UCLA right now. You know, there's a big demand for our services, and we're kind of a must-have in the network, and we can get good rates from insurance companies, and people want to come to UCLA, and we put you in the hospital, and every night you stay there, we make money. I believe that my job is to close the UCLA hospitals, because I need to get people healthy and never to be hospitalized. And I know that if people took care of themselves and we gave them the tools and we addressed the social determinants, that overnight we could get rid of 400 of those 800 people. They don't need to be in the hospital. So, but if I were to do that today, I'd lose my job. So the game is changing to where I'm going to get, or our system is going to get, rewarded for doing just that. And that's exciting. So that game is really, really happening as we speak now. We have a couple 100,000 people. We see about 2 million patients a year. We have about 200,000 right now that we're responsible for their total cost of care in some form or fashion. Our goal is to get that to about 2 million people. That will become our business. And the reason we're in business is to support our teaching and our research. So we hope to remain in business. When I was in Pepperdine, I was in the PKE program, and it was in the 2000 to 2002. So it was .com and then .com crash. And we all sat around, there were 20 of us in the room, and Wayne Strom said, there's only 2 of you that are going to be in institutions that are going to last forever, in my opinion. And these were guys, some of these guys had private planes. I said, you know, I was jealous, right? And that guy became a consultant by the end because he lost his job, everything crashed. And the 2 he said was UCLA, and the guy sitting next to me was the chief financial officer for the Archdiocese of Los Angeles. So like, and his turned out to be touch and go.
And that wasn't a real risky statement, yeah.
Exactly. So he ended up with, I talked to him the other day, actually. So we are in it for the long run. There's no exit strategy at UCLA. CHLA is not going to get out of business. So we have to change the business model so we can continue to provide for our communities.
Let me add to that, because I think you're exactly right. I mean, we have to change the business model, which means you have to change the structure of your organization. You have to get physicians, hospitals, the whole continuum. You become responsible for the whole continuum, which means wellness, your primary care, your specialty outpatient care, your hospital, which is the last place you want to put one of your patients if you're responsible for fulfilling the full continuum, including home health, hospice, and so forth, because you're responsible for everything. The question in terms of the leadership that's going to be required to make that business model change is a huge cultural shift that has to take place, because physicians and everybody that's involved right now is used to the model that David described. The more you do, the more you get. Now we have to change that. That's why everybody's trying to copy the Kaiser model, whether or not it's, but you have a group of, and it's interesting that I'm up here with 2 physicians, where you have physicians who've been practicing in private medicine, doing the business they've been doing. How do you convert that mentality for a number of people in an organization and lead around that to get to the point where David explains? That's what we're confronted with as administrators. Okay? How do you make that conversion? I'm fortunate because I had some time with Kaiser. So for me to explain it to the physicians here at Children's Hospital and recognizing that we need to do this in order to maintain an academic, and I think academic medical centers are going to have some challenges, so that how do you maintain this academic medical center? And we're a teaching hospital, so we have the clinical work. We teach the majority of the pediatricians in this community, many of them practicing solo practice out in their communities right now. And then we have a robust research program dedicated to pediatrics. Okay? So how do you take community doctors along with the academic doctors, and then you have these notions of town and gown out there, to work together in a system, in my case, for children? That takes a lot of leadership, it takes a lot of thinking and processing in order to get them there to be successful for the future. We've got a little time to do that, but it's happening real fast. Everybody's talking to everybody in this market right now.
So Artie, let me ask you a little bit more focused question, because you all have an integrated system. What has allowed you to do that and make it successful? And what are the challenges to other institutions of moving to an integrated system, given what you've seen at Kaiser?
Actually, no, I'm going to take a chance to disagree with David, because I think it'll liven up the the conversation on one point. I think that, because that's a fascinating question about what's changing.
Right.
And I'd add a couple more onto the good ones that Rich and David mentioned. One is the organization of physician practice after the model of solo physician practice has been one of the most amazingly durable small businesses, in our economy, is, I think, at last, changing at a pace where it's significantly changing. So I think that although, I know when I was in public health or business school, people were predicting the imminent demise of the independent fee-for-service practice, and it didn't happen. Yeah. That although now I think that there is an inexorable trend, helped by all of us up here, towards physicians coming into, needing to come into, wanting to come into, for both personal and professional reasons, into larger organizations that have resources and the opportunity to coordinate care. And so I think that the change in the economic model of medical practice is one of the most fundamental changes, because I think bringing physicians into organizations has many good things to do for patients and physicians. And I think, in fact, the solo fee-for-service, the solo physician on their own who maximized income by attracting and taking good care of patients and maximizing the number of billable services, both professional and ancillary there, is a dysfunctional model that no one was trying to hurt anybody, but the profit maximizing behavior of the solo fee-for-service physician doesn't head society into the right direction. So I think that's changing. I think a big change happening in practice is, the change in the availability of digital services, the internet digital services, the availability of information, the availability of peer groups to exchange information has changed what used to be the physician's monopoly on information about medical treatment and care, and has changed that dynamic. And I think now, at last, after many years, I think the evolution of technology is enabling what we'll call telehealth and telemedicine in a way which the American Telemedicine Association was created 30 years ago, and I went to their conference a year and a half ago, and the lead thing was, what is the business model for telehealth? 28 years later, it still hadn't expressed itself. But I think now we're at a point where, more and more, because of the technology, a huge portion of outpatient services and a meaningful portion of things that used to be inpatient can be provided independent of place. Don't have to be provided in a brick and mortar office or hospital, can be significantly enabled by telehealth and telemedicine services. So I think that will change things in a number of ways. The point on which I was interestingly going to disagree is that there's a lot of talk, and all of you who are familiar with this have heard that we're moving from volume to value. And which is a good thing, and it's very much how our organization has started. Well, just a little bit about what I do every day. My primary role in Kaiser is I lead the sales and marketing folks and the health plan operations folks, and our job is to go out to employer groups and individuals, and I'm successful if my people bring in $52 billion in revenue. That's my primary job: bring in customers, members, keep them, and take care of it. And what's striking is we take care of, we provide health benefits to about 100,000 employers, and most of them still would like to pay by the piece. The largest purchasers, the largest corporate purchasers in America, sort of get this idea that fee-for-service is the problem, but they have a strong bias towards, well, you know what? I really would like you just to send me claims. I'll negotiate the lowest rate I can on your claim and pay you according to that. Whereas I completely agree with David that the right movement is towards payment for value and payment towards keeping people healthy. And there are ways to do that. There are various ways to package healthcare. It's by discharge, by period of time, by disease, by episode, or by human being for a period of time. But that is an astonishingly rare way for payment to exist today, and there are significant forces, both the purchasers of healthcare in corporate America and the people who advise them who are still strongly ambivalent or opposed to moving away from the fee-for-service medicine as the way they pay your institution. You know, and in fact, Kaiser fights every day and battles every day to explain to people that we would really like you to pay us by the package so our incentives are aligned. And they said, well, can't you really just add up your hospital days and I'll pay you per day? So I'm frustrated every day, and my team goes to sell every day value rather than volume. And to tell you the truth, it's an uphill fight there, and we still have some conversion. So I agree with you on the direction, but I think it could be 25 years rather than 5, just for fun.
So let's talk for just a few minutes about the Affordable Care Act. Not that we could talk about that for a few minutes. It may take longer than that. But what impact do you think it's going to have on the state of health care and on some of these issues that you've already raised?
I think the Affordable Care Act is one of the best things that's ever happened to this nation. It is implementing. We have and had a healthcare system that is suboptimized for the benefit of people. How many people in here have health benefits for themselves and their family? Okay. Some do, some don't. What we have, there are 50 million people in America, the vast majority of whom work. Many of them work 2 jobs. The vast majority of them are young, and the vast majority are people of color. And they do not have what we have in the richest nation on earth. And the fact that they don't have what we have impairs their economic mobility, impairs their economic opportunity, and the economic opportunity and the life opportunity and the liberties of their children and their family. So I think that addressing and having a way to address the fact that, that 50 million uninsured people is a social travesty, which undermines the vitality of our country, we need to bear in mind as we struggle through the implementation of the Affordable Care Act that that is a fundamental objective of what it is about, and it will make meaningful progress on that over the coming years. I think there are many other advantages. I think it's made a lot more sense out of the insurance industry. In terms of basic logical changes, the idea of moving towards a consistent set of preventive services that are covered without cost, whether your carrier is Aetna, Cigna, United, or whether you work for company A or B. That level of consistency of definition, rather than it being a mystery what is covered, is what is necessary to make good markets. Good markets work when there's good information and consumers know what they're buying. So both the establishment of essential health benefits, the definition of preventive services, zero copayments, elimination of medical underwriting as a barrier for people to purchase health care. We all now, on January 1st, know that for the rest of our lives, regardless of our medical condition or the medical condition of our family, regardless of the history, that we have the right to buy any policy that is available in the marketplace from our choice of many carriers at a market rate. Not at 10 times the market rate, because I have diabetes, but at the market rate. So I think that there are many advances to that. There's more transparency about the insurance industry, abusive practices where insurance companies made excessive profits on certain lines of business are A, made transparent, and B, in some cases, eliminated. The fact that your coverage runs out when it gets to $1 million is also eliminated as a practice. We have a member today, for the last 7 years, his costs to us are $7 million a year. You know what? $1 million a year coverage does not protect you and your family from the things that could happen to you in life. So I think there are huge positive changes that have come to the insurance industry in that, in transparency. Gosh knows it's the country's most complicated and difficult industry. It's so balkanized, it's tough to implement. The bureaucrats sometimes didn't help in terms of the rules they made. The tendency of folks to change the rules 3 months before the date it was supposed to go live is tough. And it's imperfect. The bill is the product of a democracy. And it's the product of compromise in the legislative process. So it is not perfect, but I think it is a significant advance in social justice in this country, and I think it is also a necessary step to preserve the private industry of health insurance and healthcare, which was rapidly going downhill and deteriorating in an actuarial death spiral before it came about. So there's a point of view that's a little different than Fox News.
Yes. Richard, what would you
Yeah, no, I agree
contribute to
with,
that?
with Artie. And, you know, we talk about how long is this transformation going to take? When the employers, as Artie was saying, the employers sometimes have a different perspective and can't get there. That's really the question. There's no question in my mind we're headed in the right direction. The question is how fast can we move on this thing? The things that I worry about, at least in California, is what our crazy legislature is going to do on the small scale, things that are could be challenges getting in the way. We talked about organizing physicians, and so corporate practice of medicine is a big issue in California. Okay? It prevents us from doing things. We do workarounds and so forth, but there are laws in the books that need to be changed because we are changing. Old laws need to be changed. But then I worry about a legislature that comes up with some crazy things that can either put additional obstacles out there. You're going to see some very interesting ballot initiatives in November. A lot of them supported by SEIU. Okay? It's crazy stuff. So, so we have things like that that tell me, okay, let's watch this carefully. How can we move this along without the barriers that I see possibly in a way to accomplish the overall goal of everyone getting affordable health care and having access? I think it's great that we have what we have. I still think we're going to have problems with access. Still, the emergency rooms are still going to be full and so forth. So we got those issues. The other thing is a lot of people are getting convinced that, and we talked about this in a small group before this, are we going to an all-payer system? If the exchanges are successful and we kind of develop the model of the benefit package and so forth, are those rates going to be competitive? Are we going to see a standardization? Are we going to move towards an all-payer system in California? So those are the types of things that I have, questions. But is this the right thing to do? Absolutely, it's the right thing to do. The transformation of our industry needs to take place, and it's up to us to make it happen and have an influence on the policy that presents some obstacles to getting there.
Dave, your perspective.
I'm even more in favor, so
Oh.
I want to just...
Well, there you go. Wonderful. You know, I'm going to open it to questions from the audience, and I'll throw in some thoughts along the way or add some additional questions. But we've got a lot of people in the audience that probably would love to ask some questions, and we have a lot of people in the healthcare industry, so you probably have more in-depth questions than I might even have. So who would like to start? Oh, right over here. Wait, we got a microphone. We've got folks listening online, so we want to make sure they can hear as well.
So I need Richard to reconcile the following disconnect in my ear, what I heard. Politicians are the only solution to the problem, but they're going to screw up the problem. I'm on the screw up the problem. I think Obamacare is a disaster because there's a bunch of interns who came up with an idea which was not passed through political negotiation. We all know that. And now we have to live with something which essentially is going to go from it's not covered by insurance to it's illegal. And cash medicine is becoming more prevalent. The list goes on for weeks. So go back to my question. We needed politicians to save us, but politicians are going to screw it up. Please tell me who's on first in this conversation.
Well,
That may be an unanswerable question.
There's a federal answer, and then there's the state answer. And you know, let's look back to Medicare. I mean, when that law was passed, what did people say? Socialized medicine.
End of the world.
End of the world. And we've tweaked it and tweaked it and tweaked it. So now you have citizens saying to the government, whatever you do, don't touch my Medicare. Government should stay out of Medicare. They don't understand it, but they want their Medicare. My concern is at the state level. And I'll be very candid. I mean, labor has a lot of influence in the legislature right now and has a way of trying to get some changes to benefit their agendas that could mess this thing all up. And that's what I worry about. That's one of the things I worry about. But I think California, if you compare it to a lot of the other states, is doing very well with the exchange. I think the implementation is a lot soon. It's not perfect, but it's going to take time, folks. Anything that you implement it, even the simple things, how long did it take you to understand and run your own personal computer? It took you some time to learn it. This is a learning
Some of us
process.
are
It's
still
gonna
learning
take
how
one.
to use it.
Learning how to type. So I think it's a process. I think I must spend 30% of my time on policy work, both in Washington and Sacramento, to talk to them. My first thing is I'm here representing children. Why? Because they don't vote, okay? So you have to have an influence to make sure that we're headed down the right way.
Questions? We'll go here and then back there, right here.
Good evening. My name is Cesar Landeros. I work primarily in the senior care industry, and I'm curious to know what are your thoughts on the primary factors to open up some of the systems in terms of access to some of the healthcare systems that are currently here in California. I deal a lot with the inability to actually contract with some of the closed systems that really leave a lot of the ancillary providers providing some of the care. And so I'm concerned when I hear things like we will continue to, find trouble with access to healthcare and developing programs that are community-based and integrated medicine with providers in the community. When, in my experience, a lot of the current systems are like closed systems.
Dave, do you want to
Sure.
take that?
Can I ask you a question? What do you mean by close? Can you give me an example?
Sure. One of my primary clients is in the wound care industry. We deal primarily with providing wound care services to the seniors in the long-term care setting, and I find a lot of problems with contracting with Kaiser, for example. A lot of the times they refuse the program or they refuse to pay for services, and yet the services are not provided in the long-term care setting.
Gotcha.
And so we're looking as an organization on how do we become a more integrated service with systems like Kaiser or UCLA or other IPA or other systems, other healthcare insurance companies, to be able to deliver these services that under Medicare or Medicaid they would be receiving right now.
Gotcha. So can I answer that at a higher level, and then I'll try to get to your specific question. But the big question that we're looking at as an organization now, one of the big questions, in addition to lowering our cost and becoming more integrated, I think has to do with access. So we answer the phone differently now at UCLA. We started doing this July 1, and we're going to come public in a few months once we work out the bugs. But we answer the phone, hello, this is UCLA. Would you like to be seen today? So we have same-day appointments now for everything, because in my sense, if we become patient-centered instead of physician or organization-centered, if your wife calls you and says she's got a lump in her mammography, or your child writes in a poem that they want to kill themselves, or your elderly parent falls or has a wound on their leg that isn't healed, you need to be seen yesterday. And the way we've always run was we would want to build an inventory up of patients in the waiting room, because the doctor was the expensive person, so you don't ever want that person to have any downtime. And I think we have to flip that completely. We have to flip that. What we're going to do is we're going to eliminate our waiting rooms at UCLA. They will either become clinical space. If we do preserve any waiting rooms, there'll be waiting rooms that are just used by doctors that are waiting for patients. So patients won't wait, right? We'll know when you're coming because we'll get some beep from your car that you're in the parking lot, we'll get ready. So we will be expecting you and providing all of those services. Actually, we'll be anticipating those services. We'll know who's coming in, and by monitoring people at home, by connecting with people, we'll know who you need to see and be ready for you. In doing that, and if we're going to be ultimately accountable, so I hope I now get to your question, we got to know who's doing what to who. We got to know whether you're in our system, and we're not a completely closed system, so we have UCLA patients that go to Cedars for some of their care. We have to know what's happening, or we can't anticipate appropriately. And in that vein, as we talk about vendors, and I think we do outsource our wound care at UCLA, is there a way to make sure that that information is included in our system? And if it is, and if you can provide that care at high quality for less cost than we can build it on our own, we're going to buy it. We provide to Kaiser, with the exception of bone marrow transplant and some heart transplant, we provide all the organ transplantation for Kaiser members in Southern California. Everything else, liver, kidney, pancreas, small bowel, et cetera. I think Kaiser makes a decision every year. Is it cheaper to buy it from UCLA? Are we getting good outcomes at low cost, or should we build it ourselves? So if you're a vendor showing up at my place, that's what I go through. You may be a great guy and have a great wound care program, but is it one that's integrated well enough in my program? I'm going to be accountable for the patient. Should I build it myself? So I don't know if that answers, but I hope I did.
Oh, go ahead.
Let me comment, because as we're answering the question, I think it's the make or buy decision. As these integrated systems, remember we're talking about providing the full continuum, and I provide the hospital part, and I got great specialty, but I don't have pieces. I'm going to look for partners, and that's where you would come in. Are you a partner? The make or buy decision. But I think there's a bigger thing playing out here, especially in LA. And in Northern California, we have a pretty consolidated market already of hospitals. In San Diego, it's fairly consolidated. In LA, we've got a very fragmented hospital, at least the hospital side. So as these systems begin to consolidate, we're going to have some victims out there that are not going to make it. Some hospitals that are going to close in this area. And there will be some businesses that will close also because of the make or buy decisions you're going to make. So there will be some consequences to what's going on also. But I think the integration part ends up being, as it's been explained over and over again, is basic. But you've got a strategy that who are you going to partner with? And I've got the same question to answer.
You had a question back here, and then we'll come over to this side. Yeah.
Hi there, my name's Elizabeth, and a large percentage of your workforce is comprised of nurses and nurse practitioners, and I wondered, how do you see the role of the nurse or the nurse practitioner changing under the Affordable Care Act, specifically in areas of prevention and primary care?
I think in general, I believe the Affordable Care Act, in fact, has relatively little impact on the practice of medicine or the practice of nursing or care. Large parts of the Affordable Care Act are about insurance rules and rights and transparency and fairness of coverage and so forth. Of course, there are other dimensions. But I think that the changes in nursing practice or in any professional practice are frankly being much more driven by changes in consumer preference, the diversity of our population and the population's expectations, people's rising service expectations, the change in technologies that nurses or other professionals use, and the overall competitive environment. People are concerned about the cost of healthcare, and so they seek to find ways to reduce cost. At the same time, people highly value the most advanced technologies that we have because they save lives, and people want that at the same time, and people have come to expect high levels of service. So I think that there are many factors changing every professional's life as they do practice. I don't think many of them at all or can be attached to the Affordable Care Act. I think there would exist absent the Affordable Care Act as well.
Can I add something? I think nurse practitioners have priced themselves out of the market for primary care. So we can hire new grads to do primary care that are doctors. And when you add in the benefits and the cost of nurses and the overtime, there's not much of a difference. When something goes bad in primary care, when a person walks into a primary care office and has an AV malformation in their brain, and that comes in once in a while, the doctors pick that one weird thing up because of their training a little better than the nurses. And when you get sued, you get held to the level of a doctor, whether it was a PA or whether it was a nurse practitioner. So we love nurses at UCLA, and we love them in the inpatient setting. Where I think the nurse practitioners are really, really helpful is not in primary care, but in our specialty care. Yep. So they can get really good depth of knowledge and take care of our transplant patients, or be really great in in congestive heart failure and can really work as physician extenders or actually in under their own license in those areas, much better than I see it in primary care. So that's how we're starting to use them, where it didn't make sense anymore to do it in primary care.
I agree.
Okay, did we have a question back here? And then I'm going to come over here to this side.
Looks like all the questions are coming from the left side of the room.
I know, that's why we're
here.
going to move over here to this side next.
It used to be said that as goes Detroit, so goes the nation. Hopefully our nation may follow California with regard to health care. You gentlemen have led our industry here in this state. And I agree with you that the Affordable Care Act is arguably one of the most important and positive things that have been passed. What do you think of our other 49 states? If I can ask you to step outside of our state lines, and do you think our other 49, 48, 47 states will follow California in terms of its success of implementing greater coverage of our populations?
You know, I think the key place where states split on this issue is, in fact, their choices they're making to implement or not implement, or when to implement the expansion of Medicaid to people up to 133 or 138% of federal poverty level. You know, some states have done that, including California. A number of states have chosen not to do that. Of course, the largest of them in terms of economic impact are Texas and Louisiana, and you know, it really, it's a tough situation. Actually, I sit on the board of a not-for-profit hospital system that does business in Texas and Louisiana, and the political decision to not expand Medicaid to a very, very large population of uninsured working people will I think do damage to the healthcare infrastructure of Texas, and that leaves out the human tragedy of people not being able to access basic healthcare services. People point out that when Medicaid was originally implemented, it took Arizona about 19 years to implement it, because it was voluntary as well. Right. But I think that as a few elections evolve, the logic of expanding Medicaid it won't overcome the political obstacles, but the political rhetoric will change a bit, and I think people will broaden their coverage, is what I would hope. It'll take time.
Okay, let's bring a microphone right over here. Yeah, you.
Good evening, my name is Jose Pena, and I have a question in regards to the Affordable Care Act in regards to the death spiral. In your professional opinion, how plausible is that scenario playing out? And if it does play out, will the statutory or federal governments place something in lieu of it, or we're going to return to the status quo of our prior health system?
Just so I make sure I understand your question clearly, just describe a little bit what you mean by the death spiral of the Affordable Care Act.
They stated that when you don't have enough healthy patients that are going to pay into the system, and we're going to have more individuals that are going to require higher cost care, and we're not going to have enough individuals that are healthy that are going to pay into the system to keep it sustainable.
Yeah, I think that issue is highly overblown by the media, and it is easily manageable by the organizations who are engaged in this. You know, I think that it is important over time that you wind up engaging a broader cross-section of the population in there. I think, that will happen, particularly as people get more comfortable about the ease of purchasing, as the penalties become a little bit higher. But I think the magnitude of this problem is easily manageable. There's a lot been said about the age. You know, it's not really age, it's balancing risk pools, you know, within the age, you know, just as a real trivia. You know, our margins in the individual market, and we've been active in the individual marketplace for 40 years, our margins are modest, but our margins are higher on older people than on younger people, you know, because premiums are higher on older people than younger people. So I think there are many ways the industry can work through that issue. I think the other issue that people sometimes miss in this whole rhetoric is today the individual marketplace is 5%. With full implementation of the Affordable Care Act, it'll be 9% of the total marketplace. So there is a large pool across which this can be distributed.
All right, the woman right behind you. Let's give her the phone.
Thank you. With the implementation of the Affordable Care Act, Kaiser being one of the models that obviously was a predecessor for a lot of the concepts. Do you think we're moving towards a single payer system? And if so, is that positive or negative? Also, what are your thoughts on large employers who self-insure?
You know, on the issue of are we headed for a single payer, I think actually I believe that the implementation of the Affordable Care Act was an important step towards saving the private insurance industry and saving the private practice of medicine and not going to a single payer system, because we were in a situation before where all of the costs of the uninsured were landing on private sector employers who were forced to bear that whole cost, and it was driving employer coverage out of sight and causing that part of the industry to fall apart. So I think the Affordable Care Act may maintain the private industry and a pluralistic health insurance, health benefits industry more than if it hadn't passed. Now, whether that's a good idea or not is a matter of political opinion and debate. We all know that almost nobody with Medicare would give up their Medicare for the insurance that you guys have and that I have. Go there and ask anybody whether they, I mean, people who have Medicare could turn in their Medicare card today and probably find somebody to sell them insurance. You wouldn't do that, because I think Medicare, as Rich talked about, is the most popular and effective social program in the history of the world. So I think whether it goes to the single payer. The second part of your question was, sorry, self-insured. Self-insured employers. You know, we service 100,000 employer groups, and 20,000 of them use self-insurance as their primary means of funding their employee benefits programs. So it is a logical, well-established, 40-year-old way in which the federal government has allowed large employers to provide benefits. It works for the employers. They're the people paying the bill. And I think that that's their prerogative. If I wear my public policy hat, I think there's some shortcomings to it, but we live in a world where those employer groups are paying lots of money for the health benefits of their folks, for their workers. And this is how they've chosen to do it, and thank goodness that they make the economic commitment to provide health benefits as part of their employment package. So I wouldn't throw stones at them. Rich?
Yeah, let me add, we're seeing some trends, though. We're seeing some of these large employers start to look at self-insured models, picking up on this notion that if they funnel their workers into these narrow networks of hospitals and provider groups, that they can get discounts on that and actually save money. So this notion, and we haven't talked about narrow networks and contracting, is that I find ourselves in a situation where we're looking at it and saying, what narrow networks are being developed in the region that these employers want to use to reduce their health care. They're guaranteeing volume. What's happening? You can give a discount if you knew you're going to get certain volume from a payer. So I think there's some dynamics playing out right now with the employers going self-insured. If they think that they can save a little bit by going self-insured and not including in their expenses the overheads from a health plan, for example, and then looking at contracting directly with providers, some of those are going to test that out. And for Dave and myself, we're kind of looking at it and saying, yeah, we'll play in that game. So what I observe and what we're dealing with is that I've got to be able to be Switzerland. Being pediatrics, right. I'm Switzerland. I've got to look at who are all the payers, where are all the kids, and whoever owns those lives, I got to partner with them. So we're going to be in different models and different reimbursement schemes throughout. It's very complicated. At the same time, it is really stimulating. It's a lot of fun.
Yeah. So can I add on the single payer? So UCLA Health System is about a $2.7 billion enterprise right now. We have 800 people sitting in cubicles. Some of them are down by the airport, some are on Wilshire Boulevard. And they process bills and they get claims out. And I'm a UCLA patient. I got an MBA. I'm a physician, and I can't understand even the Anthem explanation of benefits I get or my UCLA bill.
That makes me feel a
So-
lot better.
yeah.
I'm really glad to hear that.
It's a shared experience.
Yeah.
So
Yeah, right.
I would say that those 800 people who I care about dearly add absolutely no value to our healthcare system. They have not taken care of one baby. They haven't done any stitches. And on the flip side, who are they interfacing with? A bunch of people at Anthem, at Blue Shield, and Cigna, and Kaiser that have their own cubicles and their own algorithms, and sometimes are playing games back and forth. And that friction in the system doesn't make any of us happy. So I would love to see it go away, and that be put into prevention, and that be put into better coordination of care and better communication to our patients. And that's impossible for us to affect on the provider side as long as there are still multiple payers that have that. So as an advocate for patients, I think a single payer system would drive down the cost and certainly decrease the complexity of understanding what is this EOB.
So probably just for frame of reference for somebody. So probably just for frame of reference for some people in there. So there are about 150 million people in America who get their coverage through employer-sponsored coverage. About 80 million of those are under self-funded plans. So self-funded isn't something weird. It is the way the majority of people who have employer-sponsored coverage have their coverage. It is the financing mechanism. So it's neither new nor unusual.
You know, looking at the clock, I'm going to take one more audience question, and then I have a couple of wrap-up questions I want to do because I want to be respectful of our speakers' time and everyone's time in the audience. So, Saram, I'll let you pick whoever you'd like to hand the microphone to where you're standing.
Oh,
You have authority right now,
Slip him
Saram.
a 20.
There we go. Thank you. And you know who he picked? He picked his sister. That's his sister.
Oh, he's
really? Oh,
smart man.
She owes you now.
Keep harmony in the family. It's a good thing.
Thank you for sharing your inspiring thoughts and ideas on the healthcare system. I have a question regarding what Dr. Feinberg said in previous interviews. In previous interviews, you have mentioned that the formula to the success of the medical center at UCLA has been one patient at a time. And as an aspiring doctor, that is something that I strongly look forward to doing in the future. But I was wondering, with the changes occurring with the ACA and the number of patients is expanding exponentially. Do you think that is still a viable formula for the success of the healthcare system?
I'm positive. I think I actually don't care about healthcare reform, and I don't care about philanthropy. What I care about is that any patient that comes to UCLA gets the same care that I'd want from my mom. I want it to be understandable. I want the care to be safe, of the highest quality. I want it to be culturally sensitive. I want it to be kept private. And I think if we get it right there, that everything else will take care of itself. That really, when you think about this stuff like Affordable Care Act, this is by the people. And the people that I'm responsible for, the friends and neighbors that trust their lives to UCLA, I think if I do right by them, they'll do right by us. And they'll make sure that things happen that keep UCLA being a vibrant, important part. So our purpose at UCLA is to heal humankind, one patient at a time. And we do that by promoting health, alleviating suffering, and delivering acts of kindness. I think we've also lost our way as far as being kind in this healthcare world. When you really strip down the core of our business, I go back to my Pepperdine education, the entire business is down to people caring for others. That we're just people taking care of other people. We got buildings, we got tools, we got expertise, we got licenses, but we're really there to say, when you're sick or when you're not feeling well, we want to engage with you and we want to help you get back to Girl Scouts. We want to help you get back to work. We want to get you so you can sleep at night and not be worried about your loved one. I think we've lost our way. We're obsessed around patient satisfaction at UCLA. I think it's been our best business strategy. And as long as I'm in this role, we will never waver from that. So to me, it's absolutely crucial to get back to that. It is such a privilege to be able to sit across from somebody who's not feeling well and to be able to engage in getting them better. That's the best part about being a doctor, and you're going to love it. And don't listen to anyone when they tell you don't go into this field. There cannot be a better field than be able to care for other people, because every day you're able to get rewards that you could not imagine. So to me, that's what we're doing, and this other stuff is sort of a distraction. And I know if we execute right on that, we're going to blow all that other stuff away and we're going to do really well. So best of luck to you.
Okay.
So people taking care of people is not a bad philosophy for any kind of organization
go.
as their foundation. Absolutely. So my first of the last two questions is, we call this the Dean's Executive Leadership Series. Clearly there's really dramatic change and happening in the healthcare system. And you all have been extremely successful as leaders in healthcare, but you won't be there forever. And there will need to be people that come behind you and take over the leadership in the kinds of organizations that you're a part of. What are the two or three sort of key aspects of leadership in healthcare that you think people need to prepare themselves to be able to do? So if you were really helping mentor someone into the kinds of roles that you're in, what would you say to them about being able to be an effective leader in the healthcare world that they'll face in the years
I
ahead?
say three things, and I try to live this every day. I say these words to myself as I get out of my car in the parking lot and walk in. I think you have to bring a tremendous amount of humility into what we're doing. When we make mistakes, people die. And we make mistakes. So be really humble about this. I think it's really, really important to bring passion, because you gotta see this as a purpose, as a true north, as opposed to just a job. And that's what I look for in people, and that's what I hope I bring and work very hard at. And finally, I think it's about integrity. I think it's about doing what you're going to say you do and living up to your word. That's what I look for in young people. That's how I measure my team. We talk about those words. I'm really lucky to be in this role. And this UCLA place has this world famous brand that everybody knows. And my job is not to screw the brand up. I got to have enough integrity to leave UCLA better than I found it. This is not about the leaders at this podium. This is about what our organizations represent and what they do for our communities and what the future leaders are going to have the responsibility for. So those are the things that I really look on, both internally and externally.
Let me build on one aspect, and I mentioned this to a group of students earlier in the day, is that particularly when you're leading a children's hospital, leaders have a tendency to think from their head about what they need to do and how they need to do it. But as I mentioned earlier, the culture transformation necessary to lead an organization nowadays, it's building the passion, it's building being a cheerleader. It's more of thinking and leading from your heart as opposed to just your head. And if you could accomplish that, people are going to follow you and they're going to listen to you and they're going to transform. And I think that this culture aspect of it is really a challenge for our industry, to get everybody to follow the vision of what you're trying to articulate. And as leaders, we have to be able to articulate clearly and lead behind it. And that's the challenges I think we have.
What would you like to add?
Well, actually, both those were great, and the top of my list is passion. And it doesn't matter whether you're going to healthcare or something else. If you're going to work hard, you might as well love what you do. Just the subject matter, what it's about, and I think that healthcare is the greatest place to be, just because it has such profound social purpose. My wife's a classmate from medical school. My parents were docs. I also agree it's the noblest of professions, and it's a great career. Adding on top of that passion, I think the things I'll often talk about is try to be meaningfully multilingual or multi-skilled. And by multilingual, of course I could mean English, Spanish, but it's also having a couple different disciplines which you're pretty good at and that you can relate. In addition to being pretty good at finance, being good at technology, having some skill in human resources. So I think a thing that's a good skill in general, but particularly in healthcare, is just to be able to understand and sit in the shoes of the various disciplines and professions you work with. If you can get, or if you have clinical experience, there's no substitute for having had part of your life taking care of a patient and knowing what that's about and appreciate what that is about. So I think that's a piece. And then the last piece I put in there is communication, but of communication, the most important skill are listening skills. And I think that's particularly important in dealing with diverse sets of coworkers. It's particularly important clinically, and it's sort of important for learning too.
So my last question. If you could be Secretary of Health and Human Services for a day, what's the one thing you would do that you think would have the most significant impact on healthcare in this country to make it better? Artie, do you want to start? We'll come down this way and we'll let Richard have the last word since he's hosting us tonight.
You only have one day?
That's a good
Only
question.
One day.
You have
Jesus.
a really powerful day, though. It's a really powerful day. And you don't have to take it to Congress or anything. You can just do it.
You can just do it.
Just do it.
I know it's an imaginary scenario, but let's think about it.
I have a big one and a medium size one. I think
You
that-
don't have time. You got to fix the website.
That's right. Fix the website.
My big one is that I would try to influence to make Medicaid a consistent program across the nation.
Yeah.
I think the balkanization of Medicaid by state, particularly if you're a poor person in Louisiana, is a problem, and it's just an inefficient artifact of the Johnson administration. So that's doing. And obviously, the Secretary of HHS can't do it. I think the other piece you do is probably doing a better job of fixing some things around the exchange, and particularly around the level of out-of-pocket costs and subsidies available for certain categories of working Americans. I think we still have unaffordable care that's sitting in the exchange for people who are in the particularly 200 to 400% of poverty level. I think that's something we need that would dramatically improve the result.
Dave,
Secretary?
what would you do?
Well, that's a fun job. So you go to a cabinet meeting and you get to.
And you just get to say,
It's
we're going
a
to do
good-
this.
So I
Executive
would
order.
I would get the McDonald's out of this hospital. I would do all the things that Blumberg has done in New York. I would tax the hell out of sodas. I would get audiences like this, that it's a requirement that you can't sit for this long. You got to all stand up and exercise and move. I would go crazy around prevention.
Excellent. And Rich, last word on
There's not
this.
much left in one day of having covered.
It was a busy
No,
day,
I was
wasn't it?
there, executive orders. I would look at it and say, how many executive orders could I sign in one day that would mandate governors to do things that they need to do and not futz around with the Medicaid expansion. I think that is so important to get the coverage and to expedite that. And there's another thing that I think is important is that, this state-by-state implementation of Medicaid is, I think, an issue because you get the different programs. If I could mandate, federalized Medicaid, I think would be my big push. Federalized Medicaid. One sweep of the hand, executive order.
You feel all powerful now? Very good. Let's thank our panel. You guys are fabulous. We appreciate it so much.